Hello, colleagues and friends and organizers. It's great to be together today, even virtually. But what a year. We've lost family members and relatives. We've lost AIDS activists and community members. We've lost scientists, practitioners, political leaders. We've lost dear colleagues and friends. I saw one note recently that every 30 minutes, we are still losing a healthcare worker due to COVID-19. And some countries are now experiencing major declines in COVID-19 with hope of a return to normalcy due to rollout of highly effective vaccines. But at the same time, COVID-19 continues to ravage many parts of the world. In many countries, COVID-19 is resurging. Both cases and deaths are rising. Supplies of oxygen and PPE are running out, and hospitals are full. Scarce intensive care facilities are inundated. Tiny vaccine supplies are nearly finished. And this is devastating. And yet one certainty underpins all of this. These deaths are fundamentally avoidable. Just like HIV, COVID-19 exposes and exacerbates the deep inequalities that run between and within countries and communities and affect our health, our economies, and our social fabric. Throughout the year, COVID-19 has so visibly laid bare how inequalities and social determinants have driven profound disparities in health. Racism, geography, income and education, built environment, occupation, social marginalization have driven differential exposures, prevention options, underlying comorbidities, economic vulnerabilities, and exposure to amplified violence and human rights abuses. And that's led to unequal impacts on life and survival. Yet we haven't let COVID somehow diminish our commitments to HIV and AIDS. The visibility and experiences with COVID-19 and inequalities allow us to leverage a new kind of momentum to combat the unfinished business of HIV. Amidst all of this year, the world has adopted a new global AIDS strategy for 2021 to 2026 and a new UN General Assembly political declaration called Ending Inequalities and Getting on Track to End AIDS by 2030. AIDS is not over. It is still one of the deadliest pandemics of our times. Nearly 80 million people have gotten involved and infected with HIV since the beginning of the epidemic, and over 36 million people have died from AIDS. Last year, there were 1.5 million new infections, all preventable, and 680,000 deaths, all treatable. Together, we've made remarkable achievements over the past 4 decades, which makes the disparities of who is not benefiting yet even more stark, even more intolerable, even more unjust. You know, examples of this, after all, the 90-90-90 goals that in 2016, when they were set, were felt to be aspirational and unreasonable and unobtainable, have been met and surpassed in a number of countries that vary in wealth, in geography, and type of epidemic. In fact, Switzerland and Eswatini are the 2 first countries to surpass 95-95-95. And we have cities surpassing the 95s. London was the first, as I recall. And you'll hear more about these successes in later panels. Overall progress on our global 90-90-90 landed at 84-87-90. But with that, it's not all equal. Men are further behind on the 90s than women. Children are the furthest behind of all, with only 53% treatment coverage compared to 74% for adults overall. Yet over the past decade, 20 million more people are on HIV treatment than were a decade ago. That means we've gone from 7.8 million in 2010 to 27.5 million people on treatment in 2020, a greater than 350% increase. And in many communities that previously faced high rates of AIDS mortality, AIDS deaths have become rare. But that also means 10 million people are not on treatment, about 6 million of whom don't even know they have HIV. But that also means about 4 million people have been diagnosed and yet have barriers and blockages to treatment. Sometimes these are service-related, and sometimes they're rights and policies and poverty and discrimination and stigma-related. For For some, the AIDS response is working. New HIV infections have been reduced by more than 50% since its peak in 1997. And although members of key populations now account for more than 62% of new infections globally, some key population communities are seeing rapidly falling rates of HIV. These key population community members are more likely to live in places with protective, non-discriminatory legal environments, to have access, choice, and agency to combination prevention options, including pre-exposure prophylaxis, and to have local community HIV literacy, voice, and agency in the response. But other key population communities have seen little progress and even see rising epidemics. The 1.5 million new HIV infections last year is 3 times higher than the target that we set for 2020. The gap between those for whom the response is working and those for whom it is not working is growing. And it is in that gap that pandemics persist. This new global AIDS strategy is a bold call to action to tackle the acute and intersecting inequalities that are obstructing progress. It puts communities at the forefront and maps out the changes across laws, policies, social norms, and services that are required to get us back on track to reach the end of AIDS as a public health threat. The United Nations General Assembly high-level meeting on AIDS met just last month for the 5th General Assembly convening on AIDS over the past 20 years. It was not put on hold for COVID. Rather, it catalyzed global solidarity to get back on track from unfinished business, from the setbacks of COVID, and by building on the lessons of agility and partnership from this past year. And you'll hear more about those things from WHO, Meg, and the panelists in the next sessions. We know that our resolve has been strengthened with the overwhelming adoption of the political declaration and its new and ambitious targets for 2025. So what's so new about these targets? Well, we moved to 95s or 95% coverage for most prevention and treatment services, but not just 95 as an overall national or global average, but rather 95% coverage for each affected subpopulation, so that those most affected and most missed are no longer invisible or lost in the averages. The targets also include new quantitative societal enabler targets, the 10-10-10s as we're calling them, targeting less than 10% of countries to have discriminatory and unsupportive legal environments, having less than 10% of people experience stigma or gender inequality and gender-based violence. These new targets and commitments also expand the recognition of the more specific roles and contributions of community-led organizations. Yes, community-led organizations delivering 30% of testing and treatment services, but also delivering up to 80% of key population prevention services if we're going to actually reach people how they need to be reached in ways they want to be reached and with the things they need. Delivering up to 60% of societal enabler interventions. And you'll hear more about the targets and commitments in the final sessions on Tuesday. So what does all this mean for action? Well, the new strategy and the new political declaration ask us to urgently refocus our work on closing those gaps, focusing our energy on identifying and addressing the disparities to drive a different, enhanced kind of data-driven AIDS response. These bold new 95% targets for each group won't be achievable just by doing exactly more of the same. So now is the time to rapidly work to refocus and retarget our HIV services to deliver for underserved people in ways that work for them and take full advantage of science and innovation. It's time to measure progress on inequalities and disparities, improving the actionable understanding of the complex shape of the pandemic in 2021 in order to target our scarce resources where they will have the greatest impact. And it's time to align laws and policies with science, removing punitive and discriminatory laws, policies, and practices that block effective responses to HIV. Upholding human rights is critical to building a policy environment that speeds cutting-edge HIV technologies to the people who need them most. And we will need more funding, not less, to fight AIDS and other pandemics. We must harness concretely what we've learned in AIDS the structures we have built and those we are building to help improve global capacity to prevent and respond to pandemics. This includes a rights-based approach, pandemic resilient communities able to mobilize and respond from the grassroots upwards, and data to guide agile responses directed to where the virus actually is and where it's moving to. We can do these things, but let's not pretend it will be easy. Let's not pretend we can achieve it without redoubling our political, technical, and scientific efforts, as well as leadership. And so again, I will call on all of you, the leaders who are already doing so much, to do even more. I ask you to stand up visibly and without apologies to remind folks that AIDS isn't over. I ask you to not be shy about telling people how what you do for HIV, the care, the science, the mobilization, the lived experiences, building the robust lab, health, data, and community systems, designing and delivering agile and responsive services, that this has been critical to our COVID responses as well. I ask you to promote our longstanding GPA principle, greater involvement of people living with HIV/AIDS, as a core value and component of the broader health responses, meaningful involvement of affected communities at decision-making and accountability tables. And I ask you to be brave and inquiring, to identify disparities and intersecting inequalities and systematic disadvantages that are really past failures or failures so far, so that we can achieve the remaining hardest and most impactful changes together. And I ask you to unapologetically call for the funding and the social changes needed to end AIDS. Now is not the time for AIDS austerity. Now's the time to invest and finish the job. So thank you for allowing me to join you here, and thank you and congratulations to IPAC and the organizers, and I wish you a truly successful program.
This is UNAIDS.